So in the last part, we talked about spinal syndromes, and in this last part of chapter 18, we're going to talk specifically about traumatic spinal cord injury. So you will notice that we glossed right over the sections in the book talking about pelvic organ function and some of those other things. We're not going to go into great depth on those. We're going to go right into traumatic spinal cord injury. And then in your neuro rehab class next quarter, you will talk way more about the actual treatments for traumatic spinal cord injury. We'll talk a little bit about them. We'll just briefly go over them in this class, and then you will get to practice them and go into more depth in neuro rehab. So for this section, I want you to be able to define and describe the common autonomic dysfunctions in spinal cord injury, including autonomic dysreflexia, orthostatic hypotension, and poor thermoregulation. Those are all autonomic dysfunction. I want you to define the difference between a complete and an incomplete spinal cord injury, and know how the neurological level of a spinal cord injury is determined. There's a specific definition of that. I want you to be familiar with the chart on page 378 regarding the functions at individual spinal cord injury levels. So what that chart has, why it's such a great chart, is it tells you basically what levels you're going to have, what things are going to be intact, and what things are going to potentially be a problem. So they're pretty clear-cut levels for each one, and we'll talk about those. So traumatic spinal cord injury is usually caused by motor vehicle accidents, sports injuries, falls, or penetrating wounds. The injury usually especially in motor vehicle accidents, sports injuries, and falls, they typically do not sever the spinal cord. Usually the damage is due to crush, hemorrhage, edema, or infarction. Penetrating wounds like knife or bullet wounds can sever directly neurons in the spinal cord. So immediately after traumatic injury to spinal cord functions below the level of the lesion are very depressed or even completely lost. That is considered spinal shock. It's called spinal shock. So it's immediately following trauma. It's due to interruption of descending tracts that facilitate spinal cord neurons. So stretch, withdrawal, and cross extension reflexes are all lost during spinal shock. Autonomic reflexes are impaired or lost, and that includes bowel and bladder control and smooth muscle tone. Blood pressure regulation is impaired, causing hypotension. Thermoregulation is absent. Usually spinal shock resolves after several weeks. Hyperreflexia may be present following spinal shock because overactivity in lower motor neurons causes active muscle contraction. So after the initial spinal cord injury, in that first several weeks, they don't know what the extent of the losses are going to be because of the spinal shock. After that, then they can start to classify the wound, classify the injury, and figure out what the person can potentially get back. So these are all the things that are lost during spinal shock, a lot of the autonomic and somatic reflexes as well as motor. Several weeks after the injury, most people experience some recovery of cord function, which leads to return reflex activity below the lesion. In some people, spinal neurons become excessively excitable, resulting in stretch reflex hyperreflexia. So it develops as neuroplasticity produces new synapses in the reflex pathway. So that can still happen that can still continue after the spinal shock period is over. A lot of times people are given massive doses of anti-inflammatories to help reduce the loss of function. So, spinal cord injuries are classified according to two criteria. The first criteria is whether the injury is complete or incomplete. A complete injury is the lack of sensory and motor function in the lowest sacral segment. That's the definition of a complete spinal cord injury. Incomplete injury is preservation of sensory and or motor function in the lowest sacral segment. The second part of SCI classification is the neurological level of the injury. So that is the lowest level or the most caudal level with normal sensory and motor function bilaterally. So the lowest level with normal function bilaterally is considered the neurological level of the injury. So usually that is the classification of spinal cord injuries is done by the neurologist, and it's done after the spinal shock period has finished. So if someone has damage to cervical segments of the cord with impaired upper extremity, trunk, lower extremity, and pelvic organ function, it's considered tetraplegia or quadriplegia. Lesions above C4 affect the phrenic nerve, which innervates the diaphragm, and that person will need to be on a respirator. Paraplegia is damage to cord segments below the cervical level, sparing upper extremity function. So you have impaired trunk, lower extremity, and pelvic organ function depending on the level of the lesion. So there's a nice chart in chapter 18, and it's on page 374, which talks about what is going to be intact with complete spinal cord lesions at different levels. So that's a nice chart to look at. And you can get an idea of what you can expect people to be able to do. So that is I've seen some board exam questions where they said, oh, given a person with this spinal cord injury at this level, what would you expect them to be able to achieve in therapy? So you'll talk more about that definitely in your neuro rehab class next quarter, but that's something to start thinking about. So this is the sort of the worksheet that the American Spinal Injury Association, it's the International Standards for Neurological Classification of Spinal Cord Injury, ISCOS. And this is what they use to score people on their spinal cord injuries. So it's usually done by a neurologist, but just gives you an idea of what it is. So usually when they come to PT, you're going to get an ASIA score for them that tells what their level is. So the American Spinal Injury Association developed standardization of assessment for evaluating neurological level in spinal cord injury. So they test key sensory points with a safety pin to determine that sharp, dull discrimination, light touches with cotton to determine the ability to localize light touch. So that's all done before they come to PT. That's all done by the neurologist. But you will know, based on someone's spinal cord injury level, what you can expect them to be able to do. So during spinal shock, neural control of pelvic organs is depressed. So bowel and bladder walls are atonic, allowing overfilling of the viscera, and overflow leaking occurs. Overfilling and overflow leaking can be avoided by establishing a regular bladder and bowel emptying routine. And this is done in acute care and inpatient rehab. Because of the autonomic dysfunction, the person has to learn to self-catheterize. Complete lesions at higher levels of the spinal cord cause more serious abnormalities of autonomic regulation. So if you look at that chart on page 378, you'll see the higher the level is, the more likely they are to have autonomic dysregulation. So the loss of descending sympathetic control as a result of lesions above T6 results in three main autonomic dysfunctions. Autonomic dysreflexia, which is excess sympathetic activity elicited by a noxious stimulus below the lesion. So, for example, an overstretched bladder can precipitate increased blood pressure, profuse sweating above the level of the lesion, and emptying of the bladder. If the person has a Foley catheter in place and the line to the Foley is kinked, it can cause this. So when you're working with someone who has a lesion above T6, you need to be aware of their physical state at all times. Orthostatic hypotension is an extreme fall in blood pressure upon assuming an upright position due to loss of sympathetic vasoconstriction and loss of muscle pumping action. So a lot of times, if you're working with someone with a spinal cord injury in a standing frame or a tilt table, you're going to be monitoring their blood pressure and their look the whole time, and you're making sure, because a lot of times when you're working with a standing frame or a tilt table, you're working on trying to improve their upright tolerance, and so you want to be really closely monitoring their vitals at all times and just their general look. Several years ago, I was working with someone with a complete spinal cord injury, and it was from a motorcycle accident. And we were trying to work on upright tolerance. We were on the tilt table, and we started flat, go up to 10%, 20%, 30%. And as we're going up, I was taking his blood pressure on every level. So you can spend an hour getting someone up to a 60-degree tilt. And with this particular person, and so the whole time you're letting them acclimate to a certain level, and then you're raising them up and then monitoring their vitals, and then you're letting them acclimate. So there's a lot of time for talking in between there. And this particular person, his blood pressure wouldn't necessarily show up high right at first, but he'd get this really funny look on his face. And I'd say, okay, let's take your blood pressure, let's bring you down. You really get to know your patient in that situation. But we did get it to where he could stand with braces on his legs to do things like grooming and reaching things in cabinets and stuff. So that initial stage of working on standing tolerance really paid off in the end. But it's challenging when you're first working on it. So poor thermoregulation is mostly due to lack of thermoregulatory sweating or excess sweating above the level of the lesion if it's high ambient temperature, so you have to be alert for heat stroke. In cold weather, someone can have the risk of hypothermia due to lack of descending control of blood vessels and inability to shiver below the level of the lesion. So these autonomic issues are really important to be monitored while you're working with the person. And you need to educate them about it as well. So autonomic dysreflexia in particular is a medical emergency. So because their blood pressure spikes, there is the increased risk of stroke. It's an immediate life-threatening concern when someone experiences autonomic dysreflexia. So usually the things that you see are the elevated blood pressure, but before you've taken their blood pressure, you see sweating and flushing and pallor below the lesion. So it's something that you really need to monitor for because it can be a life-threatening concern. Poor thermoregulation can interfere with the person's ability to maintain homeostasis. People with complete lesions above T6 should avoid exposure to high temperatures because of the risk of heat stroke. And signs of heat stroke include high body temperature, rapid pulse, and dry, flushed skin. Signs of hypothermia may include irritability, mental confusion, hallucinations, lethargy, clumsiness, slow respiration, and slowing of heartbeat. So you have to be aware of these things. So orthostatic hypotension, by definition, is a 20 millimeter mercury or greater fall in systolic blood pressure, or a 10 millimeter mercury or greater fall in diastolic blood pressure upon assuming an upright position. In people with spinal cord injury, orthostatic hypotension results from the loss of sympathetic vasoconstriction combined with the loss of muscle pumping action for blood return. So with other things can cause orthostatic hypotension, but that is the cause of it in people with spinal cord injuries. So severed axons in the adult spinal cord will not functionally regenerate. So some functional losses after the original trauma are caused by bleeding, pain, ischemia, inflammation, and edema. A lot of times they're given methylprednisone, which is a steroid, within 8 hours of the injury, and that's been shown to significantly reduce secondary losses and reduce the severity of lesions when it's done within 8 hours after the injury. So incomplete paraplegia has the highest rate of recovery during the first 3 months. The typical complications after SCI include urinary tract infections, spasticity, chills and fever, decubitus, which are pressure ulcers, autonomic dysreflexia, contractures, heterotropic ossification, which is the growth of bone in areas where bone usually isn't, and pneumonia, because the trunk muscles aren't innervated below the level of the lesion, and it's difficult for them to clear their lungs. Upright posture can provide some protection against urinary traction and pneumonia, and mobility can help avoid contractures and decubitus. So a lot of the things that we're doing in PT, so sometimes when you're working on upright tolerance with someone, you're not doing it because they're ever going to walk, you're doing it to prevent complications. So the kind of treatments that we're going to be doing in PT, we're doing strengthening, range of motion, and mobility. We're working on ADLs. We're working on adaptive equipment, environmental modifications, potentially body weight supported gait training, which is really fun, and functional electrical stim. We have a lot of people who come in for our functional electrical stim bike who have spinal cord injuries. So the even though, again, they might not regain their walking ability, we want to prevent complications by doing these things. So red flags for the spinal region, signs and symptoms that indicate a spinal cord lesion are bilateral alteration or loss of somatosensation, incoordination, and decreased muscle power, spasticity, muscle hypertonia, and Babinski's sign, positive, and clonus. So those are our, there's a potential for a spinal cord lesion when you see those signs. The red flags for Cauda equina, Cauda equina has sort of an insidious onset sometimes. Difficulty with urination or defecation, that is one of the top ones. So a lot of times people with Cauda equina, they first come into the doctor with low back pain. If you have low back pain and some of these other red flags, like decreased or lost lower limb reflexes and difficulty with urination or defecation, you're thinking, wow, there's something more going on. It's not just back pain, because everybody has back pain, but everybody doesn't have those other things. So a lot of times people get sent to PT with back pain, and you definitely want to make sure. I've actually had people that came in. We have at our clinic PTs that specialize in neurological diagnoses. We have ones that specialize in orthopedic diagnoses. we've had people that were referred for low back pain. They came in, and the orthopedic PT, they got put in with orthopedic because low back pain is usually orthopedic. And the orthopedic PT wasn't that familiar with the red flags for Cauda equina. Well, then they get on my schedule and they start telling me about some of these other things. And then I've gone to the PT and say, hey, I think we have something else going on. And indeed, in the case of a couple people, they really did have a Cauda equina lesion going on. So it's important that not just the evaluating PT knows these things, but we have to know them too. Intermittent claudication is a increased pain in the buttock, lower limb, or foot while walking or exercising that disappears after a brief rest. And it's neurological in origin. You'll also see decreased pulse in the lower limb and potentially cyanosis. So that's just something to be aware of. That's something that we end up sending someone back for reevaluation when that shows up.